Hello. I would like to take a moment to thank the International Center for Professional Development in Armenia for this opportunity to provide you a brief update of some concepts in pediatric urology. As you can understand, the topic of pediatric urology is vast, and therefore there are many themes which will be necessarily left out of this presentation today. I thought that since there remains much controversy in the management of vesicoureteral reflux, it would be of great help to this audience to focus on that today and specifically update you as to some of the most recent findings that have been published in the Journal of Pediatric Urology in the last year. I have no financial disclosures and would like to address the group by saying that this journey really begins in the early 20th century when vesicoureteral reflux was recognized as a means by which bacteria gained access to the kidney. The association between reflux, acute pyelonephritis, and recurrent urinary tract infections and renal cortical scarring focused our attention toward managing an anatomical problem rather than a group of variables influencing a spectrum of clinical outcomes. Our bias was informed by a late-stage presentation of children with long histories of recurrent urinary tract infection whose imaging studies documented the destructive effects of acute pyelonephritis. The radiographs demonstrated below show an example of fairly significant bilateral vesicoureteral reflux, grade 4, with calyceal clubbing that corresponds to areas of scarring on a DMSA scan. As it turned out, UTI is common among children and, at least in times past, potentially severe enough to warrant hospitalization. Children affected by UTI are at risk for recurrence, most in the following 6 months, and particularly if other abnormalities coexist, such as reflux and bladder dysfunction. We soon learned that longer and more significant episodes of urinary infection resulted in a greater likelihood of renal scarring, as well as that many children with a prior history of urinary tract infection had long-standing bacteriuria. Hidden within these early clinical studies, however, are the foundation of non-operative management of vesicoureteral reflux, which I believe stands the test of time. More recent studies have called into question the significance of urinary tract infection and vesicoureteral reflux, citing a relatively low incidence of renal cortical scarring among patients who have been recently diagnosed. However, these studies need to be taken in the context of the clinical populations being studied, and another more contemporary study from India has demonstrated that there still exists a fairly significant risk that is accrued to children with vesicoureteral reflux. Taking a mixed population of children with the presentation of antenatal hydronephrosis and either initial or recurrent UTIs, the authors found a significant association between DMSA scan abnormalities and reduced differential renal function, correlating with the presence of vesicoureteral reflux as well as its grade. And so we must remain forever vigilant as to the impact of VUR and UTI in renal health. When applied to children with a history of urinary tract infection, antimicrobial prophylaxis was found to be quite effective in reducing the rate of recurrent urinary tract infections. In this study by Dr. Jean Smelly, prophylaxis succeeded in reducing the frequency of urinary tract infections from 2.4 to barely 0.24 attacks per year per patient. Even among those with vesicoureteral reflux, antibiotics were found to significantly protect from recurrent UTI, suggesting that whatever risk VUR imposed could be mitigated. And with DUE patients, more than 80% of reflux resolved, while children remained healthy. Those with higher grades of VUR and with a history of renal scarring didn't fare as well as the majority, but thankfully, these poor responders are the minority. These data, again by Dr. Jean Smelly, demonstrate that the vast majority of children in lower grades of vesicoureteral reflux demonstrated resolution without any significant changes to their upper urinary tracts. Indeed, depending on how one slices the pie, most children who present with febrile or symptomatic UTI are predicted to be good responders, a threshold for severity being crossed at some point among those with grade 3 VUR. And let's not forget also that Skoog, Bellman, and Majd reported in 1986 their 10-year experience in managing 550 some odd patients encompassing 840 some odd refluxing units by a sigillary. Let's not forget also that Skoog, Bellman, and Majd from Children's National Hospital in Washington, D.C. reported in 1986 their 10-year experience managing 545 patients, which encompassed 844 refluxing units by a selectively non-operative approach. The opportunity to observe the natural history of reflux in a large cohort yielded decay curves with which we are all familiar. Reflux resolves in most renal units over time. The aggregation of large data sets has afforded further opportunities to refine prediction scores for VUR resolution, such as these nomograms, which were published by the group at Children's Hospital Boston. The utility of this information rests on improved counseling such that ideal treatments can be achieved in patient-centered approaches. It is important to acknowledge that antimicrobial prophylaxis has its detractors, its critics. At least 5 randomized controlled trials published over a short period of time reported no advantage from prophylaxis with Bactrim in children with vesicoureteral reflux. These became the foundational data for the American Association of Pediatrics guidelines, which took a sanguine approach to early evaluation and prophylaxis after an initial UTI. The main limitations of those RCTs notwithstanding, they are correct in suggesting that low-grade VUR is less worrisome in most children than previously thought. The American Urological Association guideline on VUR sought data on the influence of bladder and bowel disease on the management of children with vesicoureteral reflux, and they identified a rationale for addressing BBD in the overall management strategy of VUR as based on 4 observations from the literature. First, the risk of febrile UTI in children with vesicoureteral reflux on prophylaxis is greater in those with than without bladder and bowel dysfunction. 2, the rate of reflux resolution 24 months after the diagnosis is less for children with than without bladder and bowel dysfunction. 3, the rate of cure following endoscopic therapy is less in children with than without bladder and bowel dysfunction, but there is no difference for open surgery, making open surgery the choice procedure for patients who have significant vesicoureteral reflux, as well as bladder and bowel dysfunction. And 4, the rate of post-op UTI is greater in children with than without bladder and bowel dysfunction. Subsequently, PREVENT, RIVER, and the Swedish reflux trials taught us that indeed prophylaxis staves off UTIs, particularly among those with identifiable risk factors. PREVENT randomly assigned 576 children over a 10-year period to Bactrim or placebo. The median age at entry was 14 months, 64% were girls, 42% had known VUR, at least grade 3 in half, and 71% were enrolled after the first diagnosis of a UTI. UTI developed in 13% on prophylaxis versus 16% on placebo. And in the antibiotic group, the reduction in the absolute risk of UTI was approximately 6 percentage points, which appear to be consistent across all subgroups of patients. River randomly assigned 607 children over a 6-year period to Bactrim or placebo. Recurrent urinary tract infection developed in 12% of those receiving prophylaxis, as compared with 24% of those on placebo, which represents a 50% reduction in the risk for recurrent urinary tract infection. Prophylaxis was particularly effective in children whose index infection was febrile. And in those with baseline bladder and bowel dysfunction, the hazard ratio was also significantly lower in patients who received prophylaxis. Indeed, in the Swedish reflux trial, prophylaxis even outperformed endoscopic correction of VUR for reducing the risk of febrile urinary tract infection. As well as the risk for renal scarring. The Swedish reflux trial was able to define bladder and bowel dysfunction further and found emptying phase dysfunction, particularly to impair reflux resolution, while overall lower urinary tract dysfunction increased the risk for renal scarring. Taking into consideration the variables of VUR and BBD, antimicrobial prophylaxis was found in the PREVENT study to significantly reduce the risk for febrile and symptomatic urinary tract infections. So I think we can agree that while lower grades of vesicoureteral reflux in children with normal voiding, no evidence of renal scarring, and a limited history of recurrent urinary tract infections is less concerning, the evidence favors management of children with BBD, renal scarring, and recurrent UTI with antimicrobial prophylaxis, at least initially. If voiding dysfunction is a significant and modifiable risk factor, as Dr. Smelly intimated almost 80 years ago, and which has been recently verified, then shouldn't we apply a tincture of time before proceeding surgically? At this point, I would be remiss if I didn't acknowledge the bacterial resistance patterns are rendering our antibiotics less effective. And perhaps those who espouse earlier surgical correction are correct to raise antimicrobial resistance patterns as a rationale for anti-reflux procedures. But let's not throw the baby out with the bathwater just yet. It is true that antimicrobial resistance is rampant, but the same promiscuity among bacteria that has distributed resistance against Bactrim, for instance, has not affected nitrofurantoin similarly. Over time, nitrofurantoin has remained remarkably effective and should be considered our first-line agent for urinary prophylaxis. Perhaps doing so will result in many children resolving their VUR with healthy upper tracts and without the need for surgical intervention. In the study comparing multiple methods of antibiotic management for recurrent urinary tract infections in the British medical literature, there is demonstrated an excellent efficacy from nitrofurantoin, which has been stable at 95%. And what else have we learned in the last year? Well, we've learned that the application of machine learning based algorithms for quantitative analysis of vesicoureteral reflux may indeed further define the nature of clinically significant VUR. In this study, they used a web-based algorithm to define a variety of metrics which, when analyzed, could very well determine the more clinically significant grades of vesicoureteral reflux. Looking specifically at the metrics of tortuosity of the ureter, the maximum ureter width, the width at the ureterovesical junction, as well as the width at the UPJ, the authors were able to define ureteral tortuosity and maximum ureter width as the most important variables which predicted a high-grade and clinically significant vesicoureteral reflux. It is felt that using web-based artificial intelligence tools such as this may better define patients who are at high risk for recurrent urinary tract infection and therefore deserving of a more aggressive treatment. In this article, looking at contrast-enhanced voiding urosonography, the authors performed a meta-analysis of 36 studies, which included over 2,700 children and 1,370 cases of vesicoureteral reflux. They found quite excellent sensitivity and specificity for contrast-enhanced sonography to detect reflux, thereby helping us further define which patients probably are deserving of more aggressive approaches, because these studies performed much better for the discriminating of low-grade versus high-grade vesicoureteral reflux, and therefore might actually be much more applicable for screening patients with their initial urinary tract infection. So in conclusion, antibiotic prophylaxis can be effective in children with vesicoureteral reflux and recurrent urinary tract infections. The risk of scarring is affected by a number of factors. Selection of appropriate candidates for treatment with antibiotic prophylaxis should be based on these key risk factors. Nitrofurantoin is probably the prophylactic of choice in 2022 and going beyond, as well as the fact that surgical treatment is effective and appropriate for a minority of high-risk patients. Lastly, I would call your attention to the more recent articles which I highlighted today and which were published in the Journal of Pediatric Urology as tools which can enhance your ability to identify the highest risk patients and thereby better treat the children who are in your care. Lastly, not much has changed in VUR management over decades. However, our understanding of the many variables that have impacted the risk for recurrent urinary tract infections and scarring have improved to better counsel our patients. Perhaps future pediatric urologists will have even better tools at their disposal. Thank you very much.